Is your sciatica pain down your leg or pinched nerve pain down the arm caused from an inflammatory response or something else? How can you tell? Hi, I'm Chris, your herniated disc expert. So there are two primary main reasons why a person would have sciatica pain down the leg, pinched nerve pain down the arm, right? So there's nerve root pain, mechanical and chemical. The vast majority of people that have this pain, the source of the pain is mechanical, meaning it's something structural, right? So it's usually the disc. It can be the bone where the hole itself is actually a stenosis where it's a little bit closed down, or a combination of the hole being a little too small plus the disc taking up space it doesn't belong in, which puts mechanical pressure on the nerve root, right? Causing irritation down the leg. The nerves don't like compression, irritation, being pulled on, right? But they also don't like a chemical irritation due to an inflammatory response. Some ways to determine that are understanding the pain itself. So chemically driven pain will always be constant. It does not go away, it doesn't change much. It's pretty much always there at a pretty steady level, 7 out of 10, 8 out of 10. Because inflammation is a chemical response. Like when you sprain your ankle and it swells up and it's really like angry and swollen. That pain is constant, there all the time, doesn't change much. This is generally the minority of people, or it's at least in the early on stages, right? The vast majority of people have mechanically driven pain, meaning the pain changes. It moves up and down the leg, up and down the arm. There are certain activities, positions, movements, time of day that change the pain. If the pain is intermittent, it has to be mechanical. Mechanical pain could also, could be constant, but the biggest difference between mechanical and chemical would be that ability to change it, the intensity, change the location, and move it around based on position and movement. So what does that mean for you? The biggest thing is that if it's determined and likely that the pain is chemically driven, an epidural corticosteroid injection is going to have a much better chance of being effective because you're fighting a chemical problem with a chemical solution, right? Those things link up, they match. The trouble comes in sometimes when people get injections and they're putting them in there to kind of guess, or they're not sure. And when you put a chemical in and you're trying to combat a chemical problem, but what you really have is a mechanical problem, those don't link up. And so often there won't be a lot of sustained or overall improvement with that injection. It might feel better for a couple days because of the medicine just kind of numbs the area. But the difference is that when it's mechanical, it moves, it changes. There are positions, postures, activities. That is a movement-based problem. You can generally fix that with finding the correct movements, the correct loading strategies, things to move that pain first, up and out of the leg or up and out of the arm, called centralization, and then we can get the rest of it to go away after that.